So good evening, everybody. I'd like to get started. Welcome, everyone. Thank you for coming out, sharing a beautiful spring evening, listening to presentations on electrophysiology. It's flattering. Thank you for coming. So the title of our presentation is Complete Electrophysiology Services for Hospitalists and Primary Care Physicians. So the purpose here really is to make what we do, which can be fairly technical and involved, simple and straightforward to physicians who are considering when electrophysiology services may be appropriate for their patients. So I hope you enjoy. We keep this light, a little bit entertaining. If there's any questions, please feel free to jump in and interrupt at any time, and we can take your questions on the fly. So briefly, disclosure slide. Again, disclaimer, this is a broad informational talk. This isn't about specific patients or management for specific individuals. So just remember that this really is for informational purposes predominantly. We are based at Cadlick Clinic at 1100 Goethals Drive, and procedures we perform are at the Cadlick Regional Medical Center, and there's a picture there of the hospital sign in case you haven't been and need to recognize that, and also a picture from inside our electrophysiology laboratory. So we've been in business now at Cadlick for just over a year. Here is a paper article from the Tri-Cities Herald from April 8, 2014, shortly after we got started. The picture is from one of our ablations for atrial fibrillation in our lab as we started off the program. And the story is, in fact, about implantation of a subcutaneous defibrillator in a patient from the Tri-Cities and how we were able to prevent that patient from having to travel to nearby towns to obtain cardiac services, which prior to our starting this program were not available in the Tri-Cities and now are routinely available to people in this area, which is very convenient for many. So for our primary care docs and our hospitalists, what you encounter are patients complaining about palpitations, heart racing, irregular pulses, skip beats, pauses, blackouts, unexplained falls. And these frequently have electrophysiology origins, and we are very happy to be involved, to be available to answer questions, to evaluate patients who are complaining of these sorts of symptoms for a potential electrophysiology cause. So we're very happy at an informal level or at a consultative level to help you address questions of these nature. Things that we may or may not end up doing, depending on what underlying cause there may be, is device implantation and management. We do pacemakers, implantable defibrillators, subcutaneous defibrillators, and resynchronizing pacemakers, defibrillators as they are appropriate. And then arrhythmia therapy and ablation, particularly for atrial fibrillation, also for our supraventricular tachycardias. And as you recall, those are the Wolff-Parkinson-Whites, AVNRTs, and atrial tachycardias. Atrial flutter, PVCs, and ventricular tachycardia. We will take on all of these in our electrophysiology lab when that's appropriate. So this is available to you at Cadlick and through our program at this present time. So we'll start off with cardiac devices and pacemakers. Starting off simply, we all think we understand pacemakers. Pacemakers are actually very exciting right now in the updates and features which continually enter this market and give our patients more and more options. I'd like to just touch on a few things that I'm personally very excited about. One is the possibility for physiologic pacing. You know, our goal is not just to prevent someone's heart from going too slow, but to provide someone with the most physiologic heart rate, pacing rate, that individual system would benefit from, and technologies involving this. Pacemakers have traditionally been an obstacle to MRI, as you're aware. We now have MRI-compatible pacemakers for several vendors and pretty soon across all vendors, so that no longer needs to be a barrier. We have pacemakers that are capable of, in fact, treating atrial fibrillation, so delivering therapy to try to stop episodes of atrial fibrillation when they occur in individuals with that condition. Pacemakers with a resynchronizing function to prevent deterioration of the ventricle in response to very high pacing burdens in the ventricle, as we know is possible. And finally, monitoring. Once you have a pacemaker, we gain a tremendous amount of information about your heart, and that can help with other diagnoses and therapies as they manifest and are recorded, documented by the pacemaker. So when to refer to electrophysiology at the level of a hospitalist or primary care physician. Any symptomatic bradycardia is worth our consideration, or any concerning bradycardia. If you're concerned that your patient's heart is too slow, or you're wondering if there's heart blocks or the significance of certain pauses, that's a good time to get us involved, and we can help make the decision whether device therapy is appropriate for your patient and which device would best suit your patient. So here we have a simple case of a pacemaker, 71-year-old female post-aortic valve replacement therapy who had complete heart block following therapy, and we see that she was implanted with a dual chamber pacemaker. And for an X-ray post-implant, this device has all of the features that I love and look for on a post-operative X-ray, and I'll just show you those so you can help to appreciate what I look for. And first of all is the pacemaker pulse generator itself, situated nicely over the lung field. It reassures me that it's going to be midline enough that it won't be interacting with the individual's arm in any way bothersome to them. We see the two leads through the venous system come down. Nice slack on the atrial lead sitting in the right atrial appendage, and then you can see the ventricular lead just riding smoothly across the tricuspid valve and having a slight uptick into the interventricular septum, where it will safely lodge and engage the cardiac conduction system as it breaks out at that point to use the patient's own conduction system to deliver the pacemaker therapy. So those are the features that I really like, and honestly, if every X-ray looked like that after we were done, I would be just thrilled, and most of them are very close. But those are the things that I look for. So here's an example of physiologic pacing. A 71-year-old male with an ischemic cardiomyopathy found to be in flutter, rapid rates. We thought there was a tachycardia-induced cardiomyopathy, so we ablated him for his flutter, and in fact, his ventricle recovered nicely. Noted that he had quite profound sinus bradycardia subsequently, and here you can see an ECG at 37 beats a minute. And for that, he received a single-chamber atrial pacemaker this past September. So a little bit more about him. This is an exciting technology that we're very interested in, and this is the ability of the pacemaker lead to sense contractility of the heart muscle. So you think when your body releases catecholamines because you're excited or you want to exercise, that the heart's going to start beating more forcefully, and perhaps you can sense that increased contractility and select your pacing rate based on the forcefulness of the contraction. And that's what this particular pacemaker is able to do, and we hope provide very physiologic heart rates for that individual. We put only the pacemaker lead in the top chamber of the heart, so it just supplements the sinus node, if you like. Here's a 12-day monitor prior to implant. You can see that he spent 65% of his time at a heart rate less than 50 beats a minute, so he's profoundly slow. And then in the presence of that pacemaker, pacing exactly where his heart rate would initiate normally, we see this nice range of heart rates that he has achieved over the subsequent 60 days, where now he's spending none of his time less than 50 beats a minute, and his contractility is selecting nice heart rates well above that, up into the 100 beat per minute range. And of course, he feels just phenomenal having that heart rate supplementation. And in fact, our lab was recognized for implanting the first single chamber MRI compatible pacemaker, which was one of the ones that I showed you in the United States. Kind of by fluke, but we were in fact the first to implant that device, and it's nice to be on the cutting edge and to know that those things are happening right here in our own backyards. So here's another one. Pacemaker technology. Here's pacemaker termination of atrial fibrillation. This is a 68-year-old male who was referred to me for ablation of atrial fibrillation. And you can see here is his pacemaker. This is 24 hours in a day as the months roll by. And you can see the episodes of atrial fibrillation that he's having. Every dark spike is an episode on a different, or the duration of AFib on a given day. And you see he has a lot of paroxysmal atrial fibrillation, probably a good candidate for ablation. Well, the last thing the referring did before sending him was turn on Minerva therapy, which is the ability of the pacemaker to burst pace into atrial fibrillation, interrupt that rhythm, possibly. So that gets turned on at the red line. He comes into our clinic here, and you can see, wow, his atrial fibrillation is dramatically reduced, and that's because in him, the pacemaker is very successful, in fact, stopping the arrhythmia. And here you see it in action. He'll be in his AFib. We get a train of burst pacing that the pacemaker selected based on the speed of his atrial fibrillation, and it puts him in sinus rhythm. So him, without even thinking, is having his pacemaker treat his atrial fibrillation. In my experience, the algorithm doesn't work well for the majority of people, but we do find those individuals who do respond very nicely to that therapy, and it's an exciting option to have for people. And finally, resynchronizing therapy with pacemakers. So we know that a lot of pacing into your bottom chamber is probably not good for you. Here is a patient with complete heart block implanted with a pacemaker in 2008. He's had 100% pacing until 2015. And in that time, his pump function has deteriorated from 60-65 to about 45-50%, and we suspect heading south as he starts to display heart failure symptoms. So this is a case just from 3 days ago where we upgraded his dual chamber pacemaker, and here you see it on an x-ray that was performed in 2013, now adding this third pacing lead out to the lateral wall of his left ventricle so that now we can now pace the heart from both sides, improve the squeeze function, contractility of the heart, prevent that chamber from dilating, failing further, resulting in heart failure admissions presently for this particular individual. So a very satisfying device for the appropriate patient, and something that I think should be considered for many more patients who have pacemakers who are receiving a tremendous amount of pacing and suffering in some result from that burden that they're receiving. And finally, we have a marvelous diagnostics from our pacemakers. Here's a 90-year-old female who got a pacemaker for dizziness and slow heart rate. And then several months later, she activates emergency medical response again for recurrent dizziness and hypotension. This time, her pacemaker documents that her problem is, in fact, her heart going too fast rather than too slow, and it makes you wonder if that was perhaps part of her original symptom presentation. The pacemaker gives us that information. So here we have a pacemaker diagnosing a supraventricular tachycardia, has features consistent with an AV node reentrant tachycardia, and we could take her to our EP lab and ablate her arrhythmia. And now she has no issues with the heart going too fast or too slow, and is very satisfied with that result. So there, the patient benefiting from all the information that device can provide. So exciting to be in the world of cardiac pacing. More specific to electrophysiology is implantation of cardioverted defibrillators, or ICDs. And we probably all know one or several people who have an implantable defibrillator. And this technology, again, is moving at warp speed, as is pacemaker technology. There's a major problem in the United States, and that is we recognize that about 350,000 people per year in the United States are sudden cardiac death victims, meaning they die suddenly. That's on the order of 1 per hour, so you have to think that during our meeting today, someone in the United States will suffer a cardiac arrest. And this illustrates the problem. If you think the iceberg represents the 350,000 people who are going to have sudden cardiac death, all the people below water are those who are outside ICD guidelines. So we would have no basis for offering them an ICD. But they're in fact going to have an arrhythmic death and never have had the chance to be protected. Those above water are the ones who are at least meet ICD guidelines. So it would be appropriate to have implanted an ICD for them. Of those, the red circle says about 20% of those people who meet guideline criteria for defibrillators will in fact receive a defibrillator. So the protection we're in fact offering patients is low. And we can conclude that guidelines fail the majority of sudden cardiac death victims because it never predicted their death, and that providers are failing the majority of patients who in fact meet guideline criteria. So it behooves physicians to think about patients very carefully who do meet criteria, advise them of their risk of arrhythmic death, and make therapy available. So the simple rule for when to involve electrophysiology, is a primary prophylaxis device, meaning you've never had an arrhythmic event, you've never fainted or collapsed, but you have an ischemic cardiomyopathy or a non-ischemic cardiomyopathy, and your pump function is low, your ejection fraction is less than 35%. That's an appropriate time to involve electrophysiology to say what is the appropriateness of ICD implantation in this individual. And then, of course, for secondary prophylaxis, if you've had a ventricular tachycardia or ventricular fibrillation arrest that you have survived, it's obviously very important to subsequently offer defibrillator protection to those individuals. So here we see, like the pacemaker, what I would love to see in every defibrillator implant. This is a secondary prophylaxis device for a 59-year-old male, postal carrier, very fit, had sudden cardiac death episode after applying testosterone patches across his body, tried to compensate for some age-related deficiencies there, and cardiac arrested in his sleep, was resuscitated, made it to the emergency room, did very well, and received a defibrillator. So this is a Boston Scientific device, the manufacturer I use most commonly. And again, we see that the ICD nicely situated over the lung field. It's not going to interact with the patient's arm. A single lead now, as before, coursing nicely over the tricuspid valve and resting in the right ventricle. We want it low in the right ventricle, very apical, so it encompasses as much myocardium as possible when a shock therapy is delivered. And you can see this dark line here, which was not on the pacemaker lead, is the ICD coil. So should this device, battery and computer here, lead here, detect a dangerous rhythm, this device can try to forcefully pace the heart to stop that arrhythmia, and failing that, the capacitors charge up in the device and a shock is delivered between that coil and the can, as we say. So you have a huge jolt of electricity passing through all of that myocardium and resetting that rhythm to normal. So we want a minimum hardware approach. The least leads in the body, leads that are least likely to have complications. We want a physiologically shaped device, thin, with excellent battery life, so that we're changing out the battery as infrequently as possible in our patients. So those are the features we're trying to provide for patients. Historically, it's always been the ICD system that I showed you. As of the last 3 or 4 years, there's another exciting technology on the market. This is the subcutaneous ICD, and again, this is a Boston Scientific product. And this is a defibrillator, which is implanted under the skin, but entirely outside the rib cage. So it's outside your thorax. Nothing is actually going through your blood vessels and into your heart, so you're able to then avoid potential long-term complications that can arise from having hardware in your blood vessels and in your heart. Vascular injury, potential for systemic infection, issues of lead implantation and extraction, should there ever be hardware failure or infection in the decades following implantation, as our patients are now living much longer. And as the schematic shows, this is the device that goes under your skin, kind of under your armpit, sandwiches the heart to a defibrillator electrode, which is anterior under your skin along your sternum. And again, this system, should it recognize a dangerous rhythm in your heart, this device can charge up in between your shock coil, which is now here, and the device, which is sufficiently posterior to sandwich your heart. That jolt of electricity does in fact go through your body and resets the rhythm to normal. Excellent safety data, excellent defibrillator potential, and a very exciting option for our young patients who are going to live for decades, half a century or more, and we don't want to begin them on the path to device complications, which could occur very late in their lives and have a lot of significance for their health care later on. So here is one of our initial implants, a 56-year-old female, right, relatively young. She has mild coronary disease, a non-ischemic cardiomyopathy. She is at risk. And importantly, the QRS is narrow, so the chances of her needing a resynchronizing device are very low. She doesn't need the pacemaker function of the defibrillator. So for her, the subcutaneous defibrillator is a very important or a very viable option. And we can see that device, how it would appear on X-ray here, over the apex of the heart, midline on the lateral film, such that you can tell how that pulse generator and the ICD electrode here would clearly pass electricity through the myocardium should that device ever need to discharge. So even this year at Cadlick, I think we've implanted 6 or 7 of these devices in the first 4 or 5 months of 2015. So it's a technology that's really picking up. I'll touch on one more exciting technology with defibrillators, and that's resynchronizing pacemakers defibrillators. And we've defibrillators with resynchronizing function. And again, your criteria for defibrillator is that low LV ejection fraction. And now if there's bundle branch block, significant conduction system delay, as I tell patients, it takes the electrical impulse such a long time to spread across your heart. One side of your heart gets the trigger to start contracting long before the other side of your heart even knows to begin. And as a result, your contraction is very desynchronous, and your heart has a hard time recovering because it can't coordinate its contraction. And in that scenario, the resynchronizing device of the defibrillator is very important. So here we see a 76-year-old man, non-ischemic cardiomyopathy, ejection fraction of 20%, left bundle branch block, a lot of conduction system delay, and heart failure, who receives a resynchronizing device. So we can see on the ECG here a big left bundle branch block pattern, which is what we look for. Our ICD system is the same, only this time there's an extra pacing lead out here on the lateral wall of the left ventricle, nicely separated from the tip of the right ventricular lead. So if we pace both of those sites at the same time, we can synchronize that heart electrically and improve its contraction function. So we see on our ECG that left bundle branch block has changed to a nice right bundle branch block pattern, indicating that we're really recruiting a lot of that left ventricular myocardium into the cardiac contraction and tremendously improving the squeeze function of this individual's heart, helping them recover from their heart failure and hopefully helping that patient's ejection fraction improve and respond to medical therapy over time. So again, the simple thing to remember is if your ejection fraction is less than 35% on echo, it's time to involve electrophysiology about the appropriateness of ICD implantation. And we'll help make those decisions, and we'll help avoid unnecessary and inappropriate defibrillator implantations because we're all at risk of making mistakes as well. Moving on to arrhythmia therapy, away from devices, and actual treatment of arrhythmias. I'll talk first of all about atrial fibrillation, because atrial fibrillation is such an epidemic in our country, and every primary care doctor, hospitalist, internist is carrying a tremendous burden of atrial fibrillation in their practice. And it's nice to know when to reach and offer patients advanced therapy. So focusing first of all on the symptoms and significance of this problem, we know even right now that above 3 million people in the United States have atrial fibrillation, and we're expecting that number to increase to over 12 million people in the United States by 2050. That's 5% of individuals over age 65, 10% over age 75. And so this is becoming the latest epidemic. It's like blood pressure or diabetes, in that everybody is developing atrial fibrillation, and they're going to live a very long time with this condition. And it is serious. There are serious consequences with AFib. You have a 5-fold increased risk of stroke overall. That's accounting for 36% of strokes in individuals age 80 to 89 years. We know that those strokes are more disabling, they're more likely to recur, and they're more likely to be fatal than strokes happening for other causes. There's a 3-fold increased risk of heart failure in our AFib patients, 2-fold increased risk of myocardial infarction, and a 2-fold increased risk of dementia or mortality from any cause due to atrial fibrillation. And here we get a quick schematic as to why that's true. If you have blood pooling in the top chamber of your heart, blood clots can form. Those blood clots then go to your main pumping chamber, which pump those up to your brain, where they cause blockages in the microvasculature of your brain, which can cause stroke. And depending on which territory of your brain is infarcted will depend on the level of disability you receive. And here we see a picture of a gentleman, trying to regain ability after suffering a stroke due to atrial fibrillation. And we all have a strong sense of how disabling strokes can be and how atrial fibrillation can deteriorate the quality of your life instantaneously. So you may ask, or your patient may ask, do I have atrial fibrillation? So what about symptoms? This is all smoke and mirrors, AFib. Symptoms can be non-existent to severe, and we've all met those patients who are not at all bothered by it and others who are absolutely disabled. Palpitations are classic. That's the sensation of a rapid fluttering or a pounding heart rate, or simply feeling out of rhythm. You know your heart isn't coordinated and that feels off, and some people will recognize that and be very bothered by it. The most common symptom statistically is fatigue. That parallels episode duration and the rate of your heart during atrial fibrillation. You can think that if your heart is going sort of fast all the time, it's going to be like running a marathon that never ends, because actually the contraction of your heart consumes a tremendous amount of energy, and you'll have, or your patient will have, a layer of fatigue superimposed on their lives. In fact, I tell my patients that for those in chronic atrial fibrillation, that I'm expecting there to be a layer of fatigue superimposed on their life, even if they've become accustomed to that, and sensitize them to maybe fixing the atrial fibrillation will in fact give them an improved energy level that they didn't know was possible, and often we find that is the case. Nevertheless, we'll always meet those patients who are in chronic atrial fibrillation who are convinced that their energy levels are just fine, they don't have any problem at all, and leave me alone, I'm not interested in going after this. So we know that is there. I don't think that's true for the vast majority, and we're always left with those individuals who are truly suffering from atrial fibrillation and disabled by that condition and begging us for whatever assistance we can provide. Other symptoms, shortness of breath, and like I said, those asymptomatic patients. So here our cartoon character is asking, is that funny feeling my atrial fibrillation? So we know that symptoms are unreliable. In fact, 95% of atrial fibrillation episodes are asymptomatic. Suspicious symptoms are incorrectly attributed to atrial fibrillation 85% of the time. So someone has AFib, they're like, oh, there's my AFib again. In fact, they're wrong 85% of the time. And then for individuals known to have symptomatic episodes of atrial fibrillation, like they have episodes that clearly bother them, those individuals will also have asymptomatic episodes, in fact, 12 times more frequently, where even they aren't aware. So you think you have it, but you don't. You know you have it sometime, but the rest of the time you're not aware of it. For all of those episodes, the risk of stroke remains the same. And we can start to appreciate the dilemma that atrial fibrillation exists. Studies have refined who has atrial fibrillation and who doesn't. Those who tend to overestimate atrial fibrillation are those who have a significant amount of anxiety, also depression, and the underestimators are those with increased age and frequently of female gender statistically. So adjust your level of clinical suspicion appropriately to those populations. And given that AFib has such important consequences and is so difficult to predict and quantify, this brings us to another exciting management of atrial fibrillation, which is this business of continuous monitoring. So if you come to our clinic and we want to investigate atrial fibrillation or other symptoms suggestive of atrial fibrillation, probably what we will suggest to you first is an ambulatory monitor, which you can wear for up to 30 days. This results in a device on your hip, 3 electrodes on your skin, and you try to wear this 24 hours a day for whatever monitoring period we feel is necessary. And at the end of that period, I'll get this report. Confirms that the monitor was for 30 days, the indication, and it says here, atrial fibrillation was present for 30% of the time. There were episodes of atrial fibrillation where the heart certainly raced, other times when the heart was going relatively slow, and I have a very good sense of what was happening to this patient's heart, what their rhythm was during that 30-day monitoring period. Patient can press buttons if they're having symptoms. We correlate it with the rhythm and demonstrate to them that it is in fact their atrial fibrillation that's explaining their symptoms. But then you say, well, what happens if you change treatment, or they improve their lifestyle, or they go for a procedure like an ablation for atrial fibrillation? Then how much are they having? And that, of course, is a problem. The 30-day monitor will no longer apply. So long-term monitoring, enter the Link implantable loop recorder. a small device the size of a paperclip that you can slip under a patient's skin right over their chest. It will sense every beat of their heart, report every whiff of atrial fibrillation they have for the next 3 years. You can think of that as 1,000 days of continuous Holter monitoring. Can report symptoms to that device. It will report atrial fibrillation when they're not aware of it, tell us how fast the heart goes during atrial fibrillation, and compare that to how fast the heart goes during normal rhythm. So tremendous monitoring technology that is now available to our patients. And at Cadlick, we were the first implanters of this device in Washington State after it gained FDA approval in February of 2014. We implanted March 24, so you can tell Washington wasn't exactly on the ball. We were in fact the first to implant this. And to date, our clinic has been the highest volume of LINC implantations, again, in the state of Washington. And this is what the device looks like. This was our first implant. So here is immediate post-procedure. You see a little skin nick where we inserted the device, and the dashed lines show that it is in fact sitting under the skin right here. If you feel it, you can feel that it's there. To look at him, you wouldn't know. 2 weeks later, you can see that that little scar is resolving, and again, just to look at him, you wouldn't know that that device was present. So really, the patients are very unencumbered by this while we collect a tremendous amount of information. And this is what monitoring for atrial fibrillation can look like. So here is somebody, this is 12-hour axis as the months go by again, and each blue line is an episode of atrial fibrillation on whichever day that turns out to be. So we see this person is having paroxysms of atrial fibrillation. We performed an ablation procedure right at this time. As is common, they had several episodes soon after the ablation, and then the result we like to see is no atrial fibrillation in the long run. And we have the monitor to prove that there was no recurrence of atrial fibrillation, even if they have funny symptoms that suggest to them that maybe the arrhythmia is still present. We can prove that there is, in fact, nothing remaining. We get a nice graph of the heart rates that they experience when they're in normal rhythm. We can compare that to the heart rates that they have while they're having atrial fibrillation, and you can see that there's a lot of heart racing, 100 to 160 beats a minute during the AFib, so this is poorly controlled when that rhythm is present, and we can do a good job for patients and prove to them and to ourselves that we've done a good job because we have the monitoring data available for us. So just to give you a little bit more exposure to what that information can look like, here we have a rapidly progressing atrial fibrillation in a 65-year-old male, normal heart, highly symptomatic atrial fibrillation. He came to us on an antiarrhythmic medication, flecainide. Like many people, he didn't really like it for a variety of nonspecific reasons, so he stopped in the presence of a loop recorder, and we saw that even without the antiarrhythmic, he continued to have no AFib. Lucky for him, didn't need the drug. Then he starts to break through and have more episodes, and then that dense paroxysmal pattern converts to a persistent pattern where AFib is present all the time. And then we can advise this individual, if we want to get on hold of this before it's really a permanent atrial fibrillation, we need to act quickly either with another medication or with an ablation procedure. So it allows us to offer very specific very patient-specific therapy. We can advise the individual what's happening in their heart and what their options are, and then again, prove to ourselves that we've in fact succeeded in benefiting that individual. So we have a very busy ablation program for atrial fibrillation at the Cadlick Clinic. We had our program recognized in EP Lab Digest this past June, partly because it's new and partly because we're using a novel technique for atrial fibrillation ablation, which we think has improved success rates. And that extra step is that we will, before we start ablating, map the heart and atrial fibrillation, demonstrate regions of very complex high-frequency activity in the chamber, and as we perform a relatively standard ablation procedure, try to incorporate as many of those high-frequency areas into our standard ablation, neutralize them while we do what operators around the country are otherwise doing relatively blindly. And it's our anecdotal experience that we get improved results by taking that extra step or designing our workflow in that format. And feedback we've had from around the country since the publication of this article has suggested that other labs around the country are adopting our techniques at CADLIC and appreciating the improved results they're getting for their patients as well. So for primary care docs, what actually happens when I refer a patient for ablation? And that's an important question and an important thing even for me to be clear about in my mind. This is what I'd like to do. We adapt around every individual, but this is what I'd like to do. Put in a loop recorder, the link monitor, get about 4 to 6 weeks of the baseline atrial fibrillation burden, so I know, understand the problem that we're taking on as we prepare for the ablation procedure. Usually there's a pre-procedure CT in the outpatient setting. As the patient approaches their ablation appointment, we'll stop the antiarrhythmic medication 4 to 6 days prior, hold the anticoagulation 1 to 2 days prior, actually perform the ablation, reset the loop recorder so it starts counting anew post-ablation. On the evening following the ablation, we'll restart the blood thinner, restart the antiarrhythmic, discharge the patient, hopefully feeling fine on the next day, and we'll continue that antiarrhythmic medication for 3 months post-ablation. If there's no AFib after 3 months, we'll stop the antiarrhythmic and hopefully they don't need it anymore. If there's still been a fair amount of atrial fibrillation in that post-ablation period, we'll continue the medication for another 3 to 6 months and then reassess. Hopefully during that time the procedure has matured even further and that patient will no longer need their antiarrhythmic drug in their long term. And then very importantly, we return the patient to the referring doctor. So if someone's referred to us, we're not trying to scalp patients, fill our clinic with your patients. We're important that we're a service to other providers, that we do the AFib ablation, and then we continue to act as a resource to you. So refer to us, if you will, invoke our repeat opinions or repeat visits. We're happy to help, but we're not in the business of taking over patients from our referring doctors. So again, the patient will first of all get a CT scan. This tells us left atrial geometry, tells us about the pulmonary veins, how they insert into that chamber in that individual. We get that patient's anatomy, and that's going to help us actually perform our procedure, get us the best result for the individual patient. We take that image and we decompose it, removing the ribs, the accessory blood vessels, isolate the left atrium, trim the vasculature that's feeding into that chamber so that we know this is what we're working, this is the substrate we're working on, these are the veins that we're trying to isolate, this is how they insert into this patient's heart, this is what other structures they're close to, are there accessory veins, other things that we may not have been aware of, we know about them so that we can get the best result and be safe. And then in our procedure, we're taking that CT scan, incorporating it into our map, and watching our ablation lesions appear on that rendering of that patient's actual anatomy. Really helps guide what we do. Here is the electrophysiology lab in action. We have a control room with our technical staff, representatives from our mapping company, and then in the lab we have a patient under sterile drapes here, intracardiac echo, displays our electrophysiologic signals and fluoroscopy, and we work through our procedure as we described. Takes 2.5 to 4 hours depending on the clinical case and the individual challenges. So again, the ablation for atrial fibrillation, to get into the left atrium, we have to poke from the right atrium to the left atrium, cross the interatrial septum. That's called transeptal puncture. Here we have a needle tenting on the septum between right atrium and left atrium. Here you see how that looks on echo. And then we will pop across that membrane, have the computer remember where we went across, and then in that left atrial chamber, guided by the CT scan and the electroanatomic rendering of that chamber made by our catheters, we will perform our ablation in that chamber. So again, this is what our catheter tip looks like. It is irrigated. It is able to sense contact force. You can tell exactly how hard you're pressing on the wall of the chamber. We have this chimney sweep type catheter, very electrically sensitive, that we use to map the electrical signals, create the entire left atrial geometry. And between this mapping catheter and our ablation catheter, we're able to deliver the ablation lesions to neutralize this patient's atrial fibrillation in the safest and most effective way possible. So, what are the strategies for atrial fibrillation ablation? In the lab, our strategy is really dictated by the patient's clinical pattern. If you have a paroxysmal pattern of AFib, we do less ablation and we expect a better result. If you have a persistent pattern of atrial fibrillation, we do more ablation and warn the patient that the result may not be as good on the first ablation, although quite reliably the patients will feel significantly better. So in the paroxysmal case, it is simply pulmonary vein isolation. We want to go around all 4 pulmonary veins, electrically isolate them from the chamber, and then as that person's pattern of atrial fibrillation becomes more persistent, we will ablate other hot spots around the chamber. We will put lines perhaps connecting our circles of pulmonary vein isolation. Our actual workflow looks like this. Here is our electroanatomic map. This is our ablation catheter with the tip. Every time we deliver an ablation lesion, the computer marks that spot with a red dot, and we continue in stepwise fashion until we have worked our way around all 4 of the pulmonary veins, and then having completed that, we decide whether there is additional work to be done because that is a persistent pattern of atrial fibrillation that we've decided to take on in our ablation lab.
Dr. Miller?
Yes.
For total MAGE patients,
Yes.
then with this procedure, they're not a candidate, correct?
If you've had a maze,
If you've had a total MAGE.
if you've had a total maze and you've had recurrence of atrial fibrillation, we will consider an endocardial ablation. Yeah, as a second procedure. So the question is, what about surgical maze procedures done which is surgical ablations for atrial fibrillation done at the time of cardiac surgery. So a patient has their chest open for other reasons, and the cardiac surgeons can do ablation maneuvers for atrial fibrillation. Those procedures can be very effective. Like ours, it's possibility to have recurrences where somebody would benefit from a second ablation procedure. And in those individuals, we will take them to the electrophysiology lab.
And how successful are they after?
How successful are they after? We've had very good success and we've had frustration. But I think you can expect the type of success that you get with a second AFib ablation for the persistent pattern, which can increase kind of the 5-year success from the 50-60% range to the 70-80% range, and usually with significant symptom improvement.
And so when generally we see these patients after the 3-month window?
Oh, you'd have to really, after the maze, you'd have to really prove that you failed the maze. I mean, I would like to wait at least a year. Yeah. I mean, I imagine for everything to stabilize, what's the arrhythmia burden? Should we try an antiarrhythmic in the meantime, but then, failing the antiarrhythmic in that setting, then is that patient symptomatic enough that another ablation would be necessary? Usually by the time we've worked through all that, you're at least a year out. And I guess maybe in the super symptomatic person with no medical options, we'd get there within 6 months. But typically probably not before that. Yeah, that's a really great question. So just one more technique slide. These are local electrogram recordings from around this patient's atria. We've mapped these with the computer system to tell us where the fastest zones of activity are occurring, and those are marked by the red dots, which our computer has automatically tagged. And if you look at the electrograms where red dots occur, you see very rapidly firing highly complex electrical signals. Blue zones are also fast and complex, but significantly slower. And then the areas that are gray are really quite benign. We see the tissue is in fact fibrillating, but the signals are discrete. They're relatively organized. They're clearly slower than their neighbors, and we think of this as regions of the chamber that's participating in fibrillation, but it's not generating the arrhythmia. So the red dots are ones that we would try to neutralize with our catheter, hopefully while we perform standard pulmonary vein isolation maneuvers. And as we target those drivers of atrial fibrillation, if you will, we hope that the arrhythmia resolves and disappears in the more passively activated regions of the chamber in a way that we can achieve sinus rhythm. So our lab is very committed to mapping these regions out in advance and trying to incorporate them into our ablations as practically as we can do. So another figure from our paper in the EP Lab Digest showing how we've identified sites in the heart with these very rapidly complex signals, and how when we go around the veins, we are taking brief excursions to incorporate those driver regions as much as possible into our standard ablation lesion sets. That may be more than you wanted to know about what happens in the ablation lab. This is a really satisfying case of a 64-year-old man, very symptomatic, sent to us because he had permanent atrial fibrillation. Can you put in a pacemaker, please, and ablate his AV node? This is hopeless. We gave him an implantable loop recorder, started him on Ticacin. In the presence of Ticacin, he had paroxysmal AFib. Only 35% of the time was he in AFib. And most of those episodes occurred or would start at 9 o'clock at night. And once the loop recorder told us that most of your AFib starts at 9, his wife could tell us, well, that's when he fades away and I lose him. It's quite reliably at 9 o'clock. And then we can go back and say, hey, it is in fact your AFib that is causing these symptoms of fatigue. And if we can take this on and improve on these, you're going to feel better. So then we have the rationale. We need to take him to the ablation lab. Here is his map. And, with dumb luck, ablating anterior to left atrial appendage, his AFib suddenly stopped. And regardless of what we tried, we couldn't get AFib to start again. That's a very reliable sign that their arrhythmia is pretty much cured. And in fact, in follow-up, our loop recorder showed that since ablation, he's had no AFib. So you see that very dense pattern of AFib up until the time of the ablation, a few sputtering episodes, and then absolutely nothing. He's still alive because here's his average heart rates. There's just no fibrillation. And that result has been sustained, and it's one of the cases that's very rewarding for us to be able to improve someone's quality of life at that level and have such complete success in somebody who the referring cardiologist had given up hope on and said, just do the pacemaker and ablate the AV node. We'll accept the AFib and hopefully get better but still relatively unsatisfactory result for him. That moves us on to this topic of supraventricular tachycardias. These are very common, sort of the nuisance arrhythmias, if you will. Common for us is AV node reentry tachycardias, frequently in females, 4th, 5th, 6th decade of life. Electrical impulses that spin in the AV junction. We can induce these arrhythmias in our lab. We can study them, deliver discrete ablation lesions to have curative therapy with the mapping technology. We can do this at times with 0 fluoroscopy exposure, so there's no radiation dose to the patient. And those cases are very satisfying. We all know about WPWs. They're famous, often occur in young people. This was a 26-year-old state trooper with debilitating SVT. He'd literally be chasing bandits down the street and go into his arrhythmia and have to stop, and they'd get away. So it was interfering with his job. Often our goal there is to ablate the accessory pathway. Those are on the mitral valve annulus, most commonly at a lateral spot. And there's our ablation catheter going across the wall of his heart into the left atrium, out to the lateral left atrium, right on top of that accessory pathway, where we can eliminate that arrhythmia mechanism from this young person's heart and get him back in the saddle. Atrial flutters are very common in our older patients, very satisfying rhythms to ablate because they can be relentless and highly symptomatic. A fairly straightforward ablation of the cavo-tricuspid isthmus, this thing we've heard of, the muscle bridge between your tricuspid valve and the vein from your body that brings blood back into the heart. We watch the arrhythmia stop, we prove block, and our curative rates are very good. That ablation was in a 66-year-old man who is highly symptomatic from his flutter, came back to us, same patient several months later, now having an atrial tachycardia. His heart rate was 105 to 110, kind of regardless of what he did. And that was a non-physiologic response. Let us know that he had a atrial tachycardia coming from the posterior wall of his right atrium. Easy to confuse kind of with a sinus mechanism, but we were able to map to a spot that was clearly off of his sinus impulse and offer him an ablation for his atrial tachycardia put him immediately back to a physiologic heart rate, and he's been electrically stable since then. PVC ablation is a big part of our practice at Catholic. Again, something we wrote an article about for EP Lab Digest on our techniques, kind of a how-to approach for PVC ablation, and for other labs that are working to increase the PVC ablations they offer patients. Because in my clinic, these things are exceedingly common and often, you know, I wouldn't say easy, but within our realm of within reach of fixing. Here's a 90-year-old man, non-ischemic cardiomyopathy. His EF is very low. He comes in with an incessant bigeminal PVC, so I've labeled them. Here's his normal beat, normal, extra. Clicks along, interfering with his resynchronizing device. So we took on his PVC, found it in the left coronary cusp of his aortic valve. So here's his aorta. Our catheter has come up around the aorta, lowered itself into that valve, where we were able to record very early signals as that extra impulse initiates in the valve and starts to creep out before it activates, you know, the ECG signal for the rest of the heart. When we can find that very early spot, that's ground zero for the PVC, and by ablating in the lab, we can eliminate that extra beat. There's an intracardiac echo image showing our ablation catheter positioned within the aortic valve, and you'll recognize the three cusps of the aortic valve as they appear on echo. And then here's this patient having his PVCs. We start our ablation here, and within several seconds, that PVC is gone and never to be seen again. And our patient's no longer bothered by that extra beat. Allowed this man to go skydiving for his 91st birthday. He couldn't go for his 90th birthday because his beats were too bothersome. So that was a nice result for him. Here's a 60-year-old male, structurally normal heart, bothersome palpitations, 22% burden of PVCs. This one is located in the vein that wraps around the heart along the mitral annulus. Anteriorly, that vein comes very close to the aortic root, which is also very close to that patient's RVOT. All those structures within 13 millimeters of each other. We can prove this using our mapping system. Theoretically, that beat could be ablated from any one of those distinct locations, and we in fact got this one from within that venous system. So PVCs are interesting. You go into these being prepared to place your catheter in any spot in that patient's heart that is necessary, hoping that you'll have to visit as few of those as possible before you obtain success. That one requiring sort of a maximal number of visits, but ultimately snugging right up to that site of origin. And again, here we see those frequent beats. We start our ablation in the appropriate spot, and those extra beats quickly melt away here within 15 seconds and never to be seen again. So, satisfying result. There's an echo image of a patient's left ventricle. This is the papillary muscle for the mitral valve. Here is our ablation catheter positioned right on the tip of that papillary muscle where his PVC was coming from. And again, with several seconds of ablation, his PVC is completely eliminated from the tip of his mitral valve. So those are what we would call complex ablations. They're exciting. We perform several of those per month at Catholic, and again, getting very interesting results for our patients. So just to recap, for our primary care docs, our general family physicians, we know that what you're dealing with are palpitations, heart racing, skipped pulses, skipped beats, irregularity, blackouts, falls. We're happy to get involved in that level, help you look for an electrophysiology cause. We're happy to treat those if it's appropriate with any range of our technological armamentarium that I've shown you tonight, from devices all the way from pacemakers up to resynchronizing defibrillators, and ablation therapy for those nuisance arrhythmias, all the way to those very devastating and dangerous arrhythmias arising from the ventricle. So it's all available. We're happy to help. We're right next door at the Goethals building. So please don't hesitate to give us a call or give us a page. We're always available. I want to thank all of you for coming. I have a website with A lot of arrhythmia information available on it, resources for our patients, so I invite you to check that out. We have videos on these things, particularly about atrial fibrillation on YouTube. So if you go to YouTube, search on Heart Dr. Jim, I've got videos of talks like this, which our patients are appreciating, as well as some of our referring physicians. So invite you to check that out, and hope to see you soon. Please give us a call. Thanks very much.